And these are the disclosures and the hospital team. And the topic will be tips and tricks for a successful transseptal puncture. It's a technical presentation, so we as cardiologists sometimes in the congresses we come out and we say about our successes and how easy we perform everything and how good we are, and we tend to forget about the difficult moments we have when we do these operations, when we actually perform these operations. So this is the transseptal puncture is one part of the MitraClip procedure, and not only that when you are there and when you do it, you know how important, how significant is this part of the procedure, and that if you're unsuccessful in this part, then you'll probably be unsuccessful at the end of the procedure. And then when we finish the procedure, we tend to forget about it and everything is good. So talking about it, it's very important, especially for those of you who endeavor into this field in the future and start doing MitraClip or other procedures into the left atrium. So what are these procedures? Many of them, as you can see: ablation, the electrophysiologist, mitral valvuloplasty, support devices, left atrial closure, and of course all the mitral valve repair and mitral valve replacement that we'll have in the future will be transseptal. So it's not strange that the number of the transseptal punctures over the last decades have been going up all the times. And before you go to do a transseptal for your first time, be sure that you are very good in knowing anatomy, heart anatomy, and have all the preparation imaging available to understand the anatomy of that given patient, and also be able to use all the available tools for this job, meticulous technique, and be sure that you can recognize the complications early and act upon them very early. So this is the anatomy of the atrial septum from the right side. You see the fossa valve is here, the superior vena cava, the tricuspid valve, the inferior vena cava, and this is exactly the area we want to go with our needle and go through and move into the left atrium. And while it seems to be quite small, it's 1 centimeter about the diameter, as you can see, there are endless certain points where you can puncture, many options. And this is important, as I'll tell you, depending on what you want to do with your MitraClip, what type of mitral regurgitation you have to correct, or what type of other procedure you are up to. So one location certainly doesn't fit all. And you have, but you have to be into the former ovale, because there is, the septum is very thin, it can be easily punctured, you can dilate it without having to do septostomy using balloons. It's easily opening with the dilators of all our guiding catheters. If we go outside of the former ovale, then we have a problem, because that is muscular part of the septum. It's difficult to puncture, it's difficult to dilate, we have catheter buckling, we have problems there. And then the direction of our system when we cross is also very important, because as you can see, depending if we're heading towards posterior or anterior, towards the aorta, we end up at different places into the left atrium. One thing that we have to understand is that the planes of the superior vena cava and the inferior vena cava are different. So the superior is a bit forward compared to the inferior. So every time we move up, we move also anteriorly in relation to the mitral valve. So this is something that we should always remember. And it's true that every time we move posterior or anterior on the foramen ovale, at the same time we change our height in relation to the mitral valve. So when we turn posterior, we go higher, and when we turn anterior, we go lower. So these are the anatomy relationships you have to appreciate and understand before you start your transseptals, your transseptal punctures. We use the broken bone needle in all our cases, and we can give this needle different curves. The 50 degrees is the usual curve, and sometimes we have to give manually a larger curve when we have, for example, a large right atrium, and we have to go lower. But remember that every time you do that, you lose height into the right atrium. And then we have the various sheaths that we're using to carry the needle in. And then when we puncture, sometimes we use the SafeSep needle. This is the wire system that it's a needle at the end, but when it enters the left atrium, it curves backwards, so it becomes completely atraumatic, and it's so thin that even if you puncture the wall of the right atrium and you're out in the pericardium, nothing is going to happen. So it gives you this extra safety, and it's very stiff when you're in the left atrium, so your needle is always railed over this wire, so it's always easy. Sometimes in those very difficult cases that you are at the border of the muscular septum, or for whatever reason it's fibrosed or it's thick and it's difficult to cross the septum, we can do ablation, and there are commercially available system like the Baylis needles with a generator that you can do that, and there's also the approach of the poor people when we use the regular diathermy on our needle, and this helps crossing. So this is we always start with the puncture of the femoral vein. We're going up with the wire, and then with real time 3D guidance, we can see our wire here in the superior vena cava and the foramen ovale here. So we know where we're going to go. We want to come down from that area, but always with a direction to there. And here, you can see how we have the SLO sheath and the bronchial needle inside, and how we gradually withdraw the system to come down from the superior vena cava into the left atrium. And here at the end, you can see here is the SLO bronchial assembly, and I think you can see at the end the tending here. The tending we cause on the foramen ovale. This is the highest point we can go at the border with the muscle. So where to puncture? It's always good to puncture high. So in that area, I always opt to go high. And this is because you have this extra length to work your procedure into the ventricle. Unless there is this concept that if you have FMR, sometimes the coaptation line is deeply into the ventricle, and if you go very high, you may not have the reach with the system, but newer MitraClip generations and the Pascal, they're very long, so you never have a problem that is unreachable. It's the other way around. And then you should remember that you, on the three-dimensional space, you have the superior and inferior, which are related to the inferior vena cava and the superior vena cava. You have the posterior anterior, which is the anterior wall, the posterior part of the thorax. And also you have the height. And when we talk about height, we mean the height in relation to the mitral valve, which is not the same with superior, because mitral valve is always the heart is somewhere in between horizontal and vertical. It has a tilt. So that's why the high and the superior are not the same. There's always an angle between like 45 degrees, as is depicted here, between them. So remember this, because this is the common terminology when we're doing the procedure. It's different to talk about superior inferior and different about high. And how do we check that? Bicaval view for the superior inferior, and the four-chamber view to check the height here in relation to the annulus of the mitral valve, and short axis at base to check the anterior posterior. So it's very simple, as you can see. It's not that many big secrets. And here we see the tending, and when we see the tending and we're happy about how superior we are and how anterior posterior and how the height that we have, then we advance our first the safe sept. So here we check the anterior posterior, the short axis at base, we're in the middle. And here we check the height, so this is the four-chamber view, and we're really the highest we can be in relation to the mitral valve. So when we are completely satisfied, this is a very crucial part of the procedure. If you get this wrong, then the procedure goes wrong. And also, it's a part of a procedure that if you're not careful, you can cause a pericardial tamponade, and you're in trouble without doing the procedure you're planning to do. So after checking all this very carefully, you take your time, because any mistakes, this part of the procedure, you pay a lot for them. And when you cross, you saw here the safe sept going up, and then it's the time to give heparin. Don't forget this very important part of the procedure. When you cross the septum and you're into the left atrium, you give the heparin. So here is the safe sept. I don't know if the resolution is good, but you can see the safe sept going up there. And then when you have the safe sept, you advance the brachiobrachioneedle needle and you enter. Because you have the safe sept, there's no way that your brachiobrachioneedle needle can cause any harm into the left atrium. And then when the needle is on, you advance the entire system in, and you are done. And then you withdraw the dilator of the SLO. When you do that, always have a needle, a Luer lock needle, and aspire from the side port, because there is a risk of sucking in air and causing air embolism. And then you advance an extra-stiff wire, long extra-stiff wire into the left atrium, and then you start to do whatever procedure you plan to do. For the MitraClip, these are the next steps. You get the guide catheter first. So this is the guide catheter. It's now in the system, in the left atrium. Initially, you see the dilator here, and then you see how we advance it and how the dilator is through, and then the main guide catheter comes at the septum and goes through. So you watch very carefully here. You see those lines are from the dilator, these lines here, and then the thicker part is the main guide. And then we remove again the dilator of the guide catheter again with aspiration, with a Luer lock syringe here. This is a very high risk to suck in air again, and you have to be very careful. And then after that, we can direct our system. We insert our MitraClip, the delivery system, and then we always aim towards the upper or one pulmonary vein here, because this gives us more working length into the left atrium to advance our system. So here is the getting down the clip from the straight position to head towards the mitral valve, and then We check the trajectory. We see the movement. We advance just the delivery catheter. So to check the trajectory we have on both directions, so three-dimensionally. Here it's lateral and medial, and here is posterior and anterior. And ideally, we should be vertical to those planes at the same time. Sometimes, in purpose, when we have particular points that we target, we may need to be like an autohanger. So if we target to go like if we have a smaller posterior leaflet, for example, and we want to be able to catch it more easily. So there are certain cases that you don't obey to the rule of 100% coaxiality in both these planes. So this is fluoroscopy of how we advance the MitraClip, but I don't think it's important. And the complication of transseptal puncture, of course, the most dreaded is pericardial tamponade, atrial stitch that may lead to pericardial tamponade, aortic puncture, perforation. You must be blind to go there, but sometimes it happens. Air embolism and thromboembolism, which are real dangers if you're not careful, if you don't pay very meticulous attention to all the details. And this is the atrial stitch that you're very posterior, very anterior to the fossa vallis, and without understanding, you may get out first of the right atrium and then into the left atrium. So you should avoid that trigones of at the end of the septum that we see on transesophageal echo. Complications are rare, but and certainly with experience they're going down. You see here very, very low. It's 0.7% serious complications. Embolism, you should always remember that every time you remove a dilator of a sheath that is positioned in the left atrium, there is a risk of sucking in air. So always aspiration. And clot embolism, always remember to give the heparin when you do your transseptal, and always to follow up your ACTs and give additional shots of heparin as required. Sometimes when you use just the needle without the safe sept, you may get this tissue core into the lumen of the needle, and if you, for whatever reason, you flush the needle, you may get an embolism from that part. So this is something to remember. So challenging anatomy, if you have a very large left atrium or right atrium, or generally the anatomy of the heart is altered for disease, from the disease. When you have aortic root aneurysm, kyphoscoliosis, atrial septal aneurysm, thick atrial septum, and pacing wires, most of the cases they don't cause problem, except from problem in assessing the transesophageal echocardiograms, because you see a lot of lines into the right atrium. So this is an example of a thick atrial septum. In some, very rarely, you cannot cross that, and you need to do a balloon septostomy to be able to go through. And eyes has been tried and have been used by some centers for MitraClip, but it's not something that gained acceptance. In contrast, eyes is used, increasingly used for PFO closure, for the ASD closure, because the views have been somehow finalized and standardized. So the disadvantages of TE are well known. I'm not going to stay here. And certainly using TE for doing your transseptal puncture gives you this extra safety that is needed. But again, if you don't follow all the details as described earlier, and you cut curves, you may be in trouble. So specific tips, if you have a PFO, it may be difficult because it may guide you very anteriorly, so try to avoid the lumen of the PFO and get your posterior direction. If you have target to close the left atrial appendage, then you have to go a bit anterior, as I told you earlier. So your direction should be anterior, which means that you should go posterior. Because if you come at your puncture anterior, then the direction, the heading of your system will be posterior, and it will make the closure more difficult. The same thing. Thank you very much for your attention.
I don't really know if Professor Manolis or Dr. Mustogiannis are in here. In that case, Kostas, correct me if I'm wrong. Transseptal punctures have been performed without TE, probably for decades. Electrophysiologists and also you performing balloon valvuloplasties in mitral valve didn't really use transesophageal echo during the transseptal puncture. In my mind, it's not a matter of safety. It's, in mitral valve clip procedures, you need to go through certain parts of the atrial septum so that you increase the possibility for the procedure to be successful. Am I correct with that?
You're completely correct, absolutely correct. And you have to target certain areas of the fossa ovalis to go through and also attain certain direction of your system to have the right heading. Also, the height is very important. You have to measure the distance from the mitral valve.
Around 4 centimeters or something like that?
Yeah. 4 centimeters is the minimum usually. But when you start doing transseptal with transesophageal guidance, it's very difficult to go back to do it blindly. Because you have seen strange cases and things happening when you have a transesophageal echocardiography, and that you wouldn't be able to get out of the problems without this guidance, the imaging guidance. So it's very difficult, I think, even for guys that are doing balloon valvuloplasty, mitral balloon valvuloplasty for decades without any guidance. If they start using transesophageal echo for guidance for MitraClip or other procedures, to go back and do it without guidance.
So it's not only a matter of safety, it's more a matter of helping you to be more successful in the procedure itself.
Yes, exactly. At this stage, yes. It was like a case that was shown earlier of a TAVI procedure without echocardiography, that after putting the valve, they had a problem with the left main after a few hours. And when they went back, they did an IVUS, and they found that that was just a dissection, a part of a leaflet, of an aortic valve leaflet. It wasn't a native coronary problem.
Spargias, okay.
So if you had the transesophageal echocardiography during the TAVI, you would have seen that and acted on earlier. Similar.
We are out of time. I think that we must move on. Thank you, Dr. Spargias.
We have to call